Dear colleagues, today we are presenting the clinical case of a patient who came to our attention at the 19th week of amenorrhea for a routine second trimester screening ultrasound examination. During the ultrasound examination of the fetal heart, and in particular while passing through the four-chamber view, our attention was immediately drawn to the presence of a homogeneously hyperechoic pulmonary mass, SHI, measuring 21 by 9 millimeters in the left hemithorax. As the first hypothesis, based on its location and its ultrasound characteristics, this appeared to be attributable to a congenital pulmonary airway malformation, specifically the solid or microcystic variant. Congenital pulmonary airway malformation is a hamartomatous developmental anomaly of the lung, characterized by a mass of disorganized pulmonary parenchyma, with proliferation of terminal respiratory bronchioles and absence of normal alveoli. Previously known as congenital cystic adenomatoid malformation, since 2002 it has been redefined as CPAM, that is congenital pulmonary airway malformation, because the lesions are cystic in only 3 of the 5 described types. From a histological point of view, in fact, Stoker's classification recognizes 5 subtypes based on the size of the cysts. However, the histological classification cannot be directly applied to the ultrasound appearance. For this reason, Wilson and collaborators proposed a simpler ultrasound classification: cystic variant and solid or microcystic variant. The cystic variant appears as a multilocular mass with cysts of various sizes, ranging from a few millimeters to more than 10 millimeters, and with hyperechoic margins due to posterior wall enhancement. The solid or microcystic form, on the other hand, appears as a homogeneously hyperechoic mass with well-defined borders. Typically, both variants are unilateral in approximately 97% of documented cases. Only a small 3% of CPAMs involve both lungs, and in these specific cases, the lesions are generally quite large and often cause a significant mediastinal shift. The underlying etiology remains unknown, although some specific transcriptional anomalies have been described in studies. Histologically, the identified lesion involves only one pulmonary lobe, although during an ultrasound examination it may appear to extend to the entire lung when it is large. The differential diagnosis of the solid or microcystic form is the most complex, and in particular, it must be distinguished from pulmonary sequestration, right congenital diaphragmatic hernia, and congenital lobar emphysema. Among the differential diagnoses, pulmonary sequestration is the condition that most frequently presents the greatest difficulty. The only ultrasound feature that allows us to distinguish between the two lesions is the so-called feeding artery, which is always present in pulmonary sequestration and absent in CPAM. By using power or color Doppler with low PRF, it is possible to accurately identify the artery and clearly highlight its origin from the descending aorta. As for right congenital diaphragmatic hernia, the low echogenicity of the liver allows us to differentiate it from CPAM, which appears uniformly hyperechoic. Furthermore, the intrathoracic position of the suprahepatic veins, as well as the mediastinal shift, contribute to the correct differential diagnosis. Finally, congenital lobar emphysema is a lesion that may appear sonographically indistinguishable from CPAM, but it is important to include it in the differential diagnosis. In fact, a recent analysis evaluating the outcomes of solid or microcystic CPAMs diagnosed prenatally showed that in 34% of cases, the lesions were later described at birth as congenital lobar emphysema. What should be emphasized is that the prognosis remains virtually the same. I will now proceed to show you how the theory was put into practice during our ultrasound study in order to carry out a correct differential diagnosis. You can see how the study of vascularization using color Doppler allows us to rule out the presence of an artery supplying the lesion, a factor that makes the hypothesis of pulmonary sequestration unlikely. We now check the continuity of the diaphragm and, taking advantage of its characteristic echogenicity, look for any presence of hepatic parenchyma within the thoracic cavity. The absence of hepatic parenchyma, as well as the absence of a mediastinal shift, allows us to rule out a right diaphragmatic hernia. As for congenital pulmonary emphysema, We have already explained how difficult it is to make a prenatal diagnosis. It should be emphasized, however, that up to 20% of cases of emphysema may be associated with congenital heart diseases. For this reason, it is always important to perform a thorough study of the fetal heart. The heart is in situs solitus with normal axis and dimensions. The four-chamber view is normal in terms of morphology and septal continuity. The left outflow tract is normal, with the aorta arising regularly from the left ventricle and a normally represented antegrade flow-on color Doppler. The right outflow tract appears to be entirely normal, with the pulmonary artery arising regularly from the right ventricle, and a clearly demonstrated and normal antegrade flow. The three-vessel trachea view is normal, with a regular V-shaped configuration in terms of caliber and arrangement. The cardiac findings are therefore found to be entirely within normal limits. The absence of cardiac anomalies, of course, does not absolutely rule out congenital lobar emphysema, but it makes this hypothesis less likely in the current clinical context. Now let's move on to prognostic factors. The primary prognostic factor for CPAM is the onset of fetal hydrops, characterized by the presence of ascites or hydrothorax. While hydrops is present in less than 10% of cases at diagnosis, it can develop in 30% of cases during the follow-up period. In the presence of hydrops, the rate of perinatal mortality is very high. The main prognostic tool available is the CPAM volume ratio, which is commonly referred to as the CVR. It is calculated by dividing the volume of the lesion by the head circumference. A CVR greater than 1.6 carries a 75% risk of hydrops. A CVR ratio less than or equal to 1.6 is associated with a 17% risk. The natural history of the lesion is progressive. In fact, it is characterized by rapid growth between 20 and 26 weeks of amenorrhea, a plateau after 26 weeks, and frequent regression in the third trimester, with the lesion often disappearing on ultrasound. In approximately 10 to 20% of all cases, a nearly complete regression of the condition is observed. Furthermore, if hydrops does not appear by the 26th week of pregnancy, it is very unlikely that it will develop later on. It is very important to explain to parents that postnatal MRI is an essential step. In fact, even when the lesion is no longer visible on ultrasound, it is actually still present and can be detected by a more detailed MRI scan. CPAM is not usually associated with syndromes or chromosomal abnormalities, and for this reason, karyotype analysis is only indicated in cases where there are associated extracardiac malformations. The clinical management during the prenatal period is essentially based on a series of ultrasound monitoring sessions to detect the early signs of hydrops. Intrauterine treatment should be strictly limited to cases complicated by hydrops and typically involves performing either a cyst aspiration or a thoracoamniotic shunting procedure. Both of these procedures have been shown to significantly improve overall neonatal survival rates. Postnatal therapeutic management involves a lobectomy within the first 12 months of birth. This should be performed even if the newborn is asymptomatic, due to the potential risk of infection and the low but present risk of neoplasia. The surgical technique used can be thoracotomy with lobectomy, but the endoscopic approach is increasingly being adopted. In terms of prognosis, if hydrops is absent, the survival rate is generally unaffected with no functional limitations. On the contrary, neonatal death is common in cases complicated by hydrops and in which no intrauterine procedure has been performed. Broadly speaking, the overall survival rate for cases of CPAM diagnosed prenatally is approximately 80% of all cases. In conclusion, the most critical aspect of management is to closely monitor the risk of hydrops every 4 weeks and to provide comprehensive and balanced clinical counseling, emphasizing that in the vast majority of cases the prognosis is good or very good, especially in the total absence of hydrops.